My name is Stephen Wilder. I'm a program manager with the National Institute for Medical Respite Care. It's really wonderful to see some friendly and familiar faces here, and I hope I have an opportunity to meet many more of you this week. I'm really happy to introduce our next group of presenters representing the community of Waterbury, Connecticut, and they're going to share their experience and some lessons learned from a recent initiative to plan and begin designing a medical respite program for their community. I'm especially excited about this presentation because I think it's so valuable to be able to spotlight a real-world example of what this program development and planning process can look like, and really highlight key components like systematically assessing and articulating the need for medical respite care in a community, leveraging community partnerships, so engaging stakeholders, making sure that the right voices and expertise are at the table during the program development, and then using this needs assessment and this community expertise to really develop a business plan and project the resources that are going to be needed to build and sustain a medical respite program. So with that, I'm happy to introduce Aparna McCullough with CONRESNIC, Rebecca Stauffer with CONRESNIC, Angie Matthis, and Becky Zadlow with the Greater Waterbury Health Partnership. Please welcome them. Thanks for being here, y'all.
Thank you, Stephen. It's great to be with all of you beautiful people here in beautiful Baltimore. We're really excited to share with you some of the things that we went through during our planning process. My name's Aparna McCullough. I am a principal at CONRESNIC. It's an accounting tax advisory firm, but we have an incredible community health industry practice where we provide various services, which here on the slide. And we were engaged by the Greater Waterbury Health Collaboration Coalition Partnership to work with the various stakeholders after identifying a need to really transition homeless individuals into a place where they can have some stability and shelter and also recover from their various medical chronic issues. And so we were asked to help design and create a business plan. And what you'll hear today is the process that we undertook, the challenges that we had to sort of process through, I would say, and the information like data that is required, the type of workflows that are required, and you'll hear at the end recommendations in terms of making sure your process as you develop it, which can be nuanced in the communities that you live in, sort of have these fundamental work steps, if you will, to help you guide and prepare and create a roadmap to launch your medical respite program. So I'm gonna pause here and ask Angie to introduce herself and the Greater Waterbury Partnership and all of the different stakeholders that were involved.
Good morning, everyone. Hi, it's nice to see you here. I'm Angie Matthis. I'm the Executive Director of Greater Waterbury Health Partnership. So I'm just going to provide some context about who we are and what we do, which I think will help the folks in this room better understand the relationship between our role kind of as a convener and the provision of data and how to kind of structure a project like this. So Greater Waterbury Health Partnership is a collaborative nonprofit health partnership under the fiscal sponsorship of an FQHC. And so, other communities have similar arrangements, and this is a relatively new and innovative arrangement in the state of Connecticut. And so our partners are a couple of our local health districts, in one called Chesprocott, which is made up of 3 smaller towns, the city of Waterbury, the Connecticut Community Foundation, Trinity Health of New England, and St. Mary's Hospital, Staywell Health Center, who is our fiscal sponsor, the United Way of Greater Waterbury, and Waterbury Hospital. And our role as a health partnership is a cross-sector collaborative partners working together to advance improved health systems, health outcomes, and data collection for the purpose of greater health equity. So some of our work that we will sort of position in this project that we worked on with Cone Resnick and with others today, importantly, is around care coordination, where we work with quite a few homeless individuals in an integrative clinical and community project called Community Care Team. And you might be familiar with models like that. And I noticed in the session earlier some talk around super utilizers. And so we leverage about 16 staff that include licensed clinical social workers, case managers, administrative staff, to identify super utilizers in our 2 hospital health system. We're a mid-sized city of about 114,000 individuals in the urban center, a larger regional in the surrounding towns. So we have quite a few challenges in that community. And the biggest challenge being very fragmented and disjointed healthcare. We also have 3 FQHCs, one focused on behavioral health. So it's really important for the partnership to take this collaborative approach with all of these organizations. So not just the ones listed on the board, some of those are our funders, but we really work to convene cross-sector partnerships across the city to address these issues in our community around not just homelessness, but behavioral health issues and substance abuse, and how to have better discharge practices, better overall care and safety nets for these folks who are really struggling and really bounced around through the system. So we've worked with Cone Resnick on another project, and we were really thrilled to work with them again on this one. And so we helped kind of convene the other folks on this project as well, and I know that they'll get to that part a little bit later. So I'm just going to move on to the next slide and talk about the medical respite need. So, you know, I talked a little bit about our work, and I think the need was always there for us. And so through our work with this community care team, which we're now in the 3rd year of, so we piloted that program beginning in 2019. And one of the things that we noticed right away was that homelessness was really affecting the majority of the overutilizers of our health system. And so I'm going to move to the next slide, and it'll provide a little bit more insight on exactly who our clients are. We're a very small operation, okay? So despite who you see here today, just know that the struggle is real, right, in this type of work, and that often I'm running around between 2 hospitals and really sort of trying to fly the plane and build it at the same time. So if you're in a similar circumstance, hang on. So this program has started very small, with just 12 clients, and today we have about 53 clients. But if you know anything about overutilization and the homeless population in hospitals, you know that 53 clients is probably equivalent to 353 clients, right? So they have a ton of social determinative health needs, a ton of you know, really unmet needs and barriers to just about everything that they need to just survive. You know, let alone getting primary care or specialty care or inpatient detox or anything else that they might need. So this is just a kind of a snapshot of what those clients look like, and they're shared between our 2 hospitals, and really they're shared between all of those FQHCs as well. So they all have housing needs. You can see on the table at the top the various categories of you know, housing status or housing vulnerability, I guess you could say, literally homeless, housed but at risk. And then you can see their diagnosis. So we have, you know, well over half are dual diagnosis with mental health and substance abuse issues. So these are, you know, members of the community that are really, really struggling, not just with homelessness, but with very, very sincere needs around you know, substance abuse disorder, mental health, medication compliance, all kinds of things. They're just really struggling to just kind of stay on top of their daily lives. And then you can see our program demographics. They're primarily male. I would say 90% of our clients are male, and well over half of them are people of color. So you know, the clients are caught in a system of hospital discharges and readmissions because of no suitable respite facility for them to stabilize in. And so what does that mean? What does that even look like, right? Well, from personal experience, I can tell you it's very frustrating, you know? So if you're thinking about what it might feel like to operate a program like medical respite, and you take a look at what's happening in your health system or your local community, frustration for me is the #1 issue, right? So we get oftentimes with our case management so close with a client to getting them stable, medically stable, but hospital policies and discharge policies often prevent us from reaching that ultimate golden ring of stability, because we can't locate a treatment bed or a detox facility for them fast enough to meet that discharge deadline. And so if these clients had the opportunity to transition to a medical respite facility, if it existed in Waterbury, there would be, number one, much greater collaboration and success between all of these partners, probably much less frustration. But the number one thing is that our patients and clients would have much better outcomes, right? If they had an opportunity to stay somewhere for 2 weeks, 3 weeks, 30 days, and have their wounds addressed, have some of their other secondary chronic conditions stabilized, they would be more successful in the community. They would ultimately be more successful in their housing situations when we've identified those for them. And then, I think just long term, right, have better chances of just living their lives in our community as regular people do, as is their right to do. And so I hope that's providing a little insight as to why we have this demonstrated need. It's not just our program. It goes across the board with many shared patients in the community, but I think we see it intensely in the community care team because of the focus on the shared case management of the individual. So we have about 45 different partners that meet every 2 weeks. And we collectively case manage the patients in the community care team. So, through our licensed clinical social workers and our case managers, and then through housing and homeless outreach and substance abuse and homeless shelters and hospitals and clinicians and other social workers and Department of Mental Health and Addiction Services, we really kind of wrap our arms around those folks to just get them whatever they need. Often we're doing case management live, and we also have folks on from the emergency departments directly monitoring inpatient and referrals as those are happening. So a lot happening, right? I have lost my mind in the last 2 years on this program. I'm here to tell you that. But I'm not giving up yet, and I do believe that this could be a reality in our community. So I think now I'm going to turn over to Becky to talk about, so Becky's our data analyst. I'm going to bring her up, and she's going to talk a little bit about some data and statistics around Waterbury's unhoused population.
I'm much shorter. I have to go down a lot lower, sorry. My name is Becky Zadlow. I am the data analyst at Greater Waterbury Health Partnership. And before I get into what this graph tells us, it's more, I want to talk about the barriers I had to overcome because homelessness is not something that our hospital system was collecting. So we had to kind of get creative in terms of how we're going to identify these individuals so that we could get data to support our need. So we took three different data sets, and we used the BNL data, which I forgot what that stands for. By name list. Oh, by name list. I'm sorry. I just drew a blank there. So we used that data. We also used St. Vincent de Paul. That's one of the shelters in Waterbury. We used their data. And then we used the city of Waterbury, and we used our hospital data through the city of Waterbury. Now, they do not collect, we need to connect the hospital visits to those homeless individuals, and they don't collect that information. So we had to get creative and say, how can we identify this? So we used the address of the hospital, we used ones that said none, we used ones that were blank, and then we tried to merge them and see where we can find commonalities. So, and another barrier is that we are a 2-hospital community, and one of our hospitals, which is located very close proximity to our homeless hospitality center, we had to go through a huge data sharing agreement to get that, and by the time this was all done, we finally got the signature that we needed. So we had to make some inferences, but however, you can see that 9%, Waterbury is 9% of Connecticut's unhoused population. Connecticut experienced a 10.7 decrease in the homeless population because of COVID, because they had systems in place, but a 32% increase in the unsheltered. So that speaks for itself. Here it just goes into demographic and age, as well as race and ethnicity for each of those data points. Yeah, well, I just wanted to, yes, yes, yeah, you probably should.
Okay.
Thank you, thank you.
Okay, so I'm back. And, Becky talked a little bit about how we collected that information. And so I do want to kind of highlight, again, some of the challenges that come up, right, when you're trying to collect information that maybe hospitals aren't typically used to providing, especially to community-based organizations. And so we did have an active data sharing agreement with both of our hospitals, and through the process of working with the other one, they wanted to renew it and make it a little more specific. So that spanned over 8 months. So sometimes there's a lot of red tape and other things to get through just to even get the information. But really, I think through the information that we did get through our own personal experiences with our client population, and working with CONRESNIC, we were able to identify the need for respite services in Waterbury. But also, these are just general definitions of that, right? Characteristics of the target population with the U.S. Department of Housing and Urban Development. Definitions for homelessness being literally homeless, imminent risk of homelessness, homelessness under federal statutes, attempting to flee domestic violence, the drivers of hospital and ED utilization, are unstable housing, chronic illness, food insecurity, inadequate access to primary care, access to medication, shelter and safe space, other social welfare needs. I mean, we're definitely seeing all of those in Waterbury. Diagnosis and health status for the homeless, cardiovascular disease, diabetes, HIV, acute psychiatric disorders, respiratory tract infections, skin conditions, substance use disorders, wound care, definitely seeing all of those, right? I think all of those, particularly for us, the co-occurring health conditions paired with substance abuse disorder and mental health and behavioral health disorders really make our population complex and not only difficult for us to deal with very little resources, but extremely difficult for our two hospital system and even our FQHCs to work with when there's not a lot of coordinated stuff going on, and certainly no homeless respite care. So I think I'm going to turn it over to Rebecca. So Rebecca Stuffer.
Hi everyone, I'm Rebecca from CONRESNIC. So as Angie and Becky have shown you, clearly Waterbury had a need, and one of the things that this slide is showing is characterizing who the target population is by definition, because we had a lot of different groups that were defining who are individuals experiencing homeless who would need to be eligible for this program. Because one of the first things we needed to do was define who's going to be our target population. Because the goal of this was to break this cycle. We know that this is the current hospital homelessness cycle, and that our goal for medical respite for the Waterbury community was to break this so that people would be able to stabilize and move into housing. So from all of the work that Becky was able to do and overcome all of those very substantial barriers, we had an idea that there was around 89 unique individuals that met the characterization and criteria and had significant amounts of reoccurring admissions, and that their admissions were more than just a day, and that they were really sitting in these hospital rooms because they had no else place to go to really recover. So that drove us to say, what is Waterbury's program design? What is it going to look like, taking into account all of the partners that the GWIP had brought together and everyone who was involved in it? And so as Angie had mentioned before, there was this collaborative had come together. They had identified within the GWIP, GWIP had identified within Waterbury that there was going to be this homeless respite collaborative. And so all these entities kind of came together and said, we know that we need to work together, and that they are representative from the hospital world, the healthcare world, the shelter world, the housing world. And we as CONRESNIC were the conveners who helped this collaborative figure out what is the design of their program going to look like, and who are they going to serve, and who's going to play what role. So, everyone had this ideal, but really what does it look like to put this on paper? And so we started with, well, what are the project objectives? And so we knew that we needed to quantify, hence why Becky had to do all of her amazing data work, the number of homeless individuals who are going to be meet the HUD definition, which was a whole conversation the collaborative need to have, is who are we going to define as homeless? And whose definition are we going to use? And that helped us create this profile of the target population. And by doing that, we were able to sort of create criteria of who was going to be eligible for the medical respite program and who's going to be ineligible. And we went through a guide in terms of asking very specific questions in terms of ambulatory abilities. What kind of healthcare needs? Is this going to be all-encompassing to cover behavioral health, substance use, primary care, or just primary care? Because that's going to get to the services and what your staffing plan is going to look like. So what is this medical respite going to cover, and who's going to come in, and how, and what are going to be their health criteria of what are they going to be able to, stay within the medical respite program with? So now we have an idea of who was the ideal patient of a kind. So from that, we then wanted to make sure that we understood what are the needs of all of the partnerships, but also what is the need of the community. So we did stakeholder interviews, and we interviewed not only everyone who was part of this collaborative, but we also talked to the philanthropic and public resources. So we talked to the funders of this collaborative. We talked to the steering committee for GWIP, but we also talked to city council people, the community partner leaders in terms of who was going to be responsible for city funding and resources, and also the local public health department. But being at Cohn-Resnick, we also knew we were not experts in medical respite, so we needed to go and talk to the experts in the field. And so we pulled from our resources and the connections that the Waterbury community had, and we talked to experts from Connecticut, Massachusetts, New York, and our friends here at Nymark. We had a really good stakeholder interview with them. Then we had an idea. So we know who we're serving, and we have an idea of what to do and not to do from all of our research. So what does this program model look like? So we then developed a program model that was going to be sustainable and reasonable and meet the needs of Waterbury's community. And by doing that, we were able to identify who are going to be the resources, who are going to be the services, who's going to really do what. And from doing that, we were able to kind of create what this plan will look like. And I'll get to that in just a second. And then finally, so we have an ideal, we have a plan, it's really pretty with graphics on paper, but what is it going to mean to make that real? What are going to be your costs? What are going to be the revenue? How is this going to run? What's going to be sort of the sustainability aspect of this ideal? And so that led us to create a business plan. And that was, we were able to quantify what those resources were and establish what are going to be startup costs, what are going to be some funding resources for those startup costs, and then what are going to be your ongoing operating costs, and then what would be future funding opportunities to make sure that this program that is highly needed is going to be sustainable to really serve the Waterbury community. And so we create, this is this long-term solution. So, as you all know as the experts here, the goal of medical respite is to break that homeless and hospital cycle. We wanted to, end this with housing. So we needed to find a way that Waterbury could stabilize individuals and then find a way to get them into housing. And we had the housing people at the table. Part of that collaborative was people who were putting individuals into housing. And so we created this kind of, this workflow where you have someone who's coming in from a homeless patient, who's a person experiencing homelessness is coming into the hospital, but then they are, getting their care, and then they would come out of hospital and get charged to the Waterbury Medical Respite Care Program, which is kind of this nomenclature we set up, and there they would be able to recuperate and receive not only their healthcare services, but supportive services. They would get enrollment, they would get social service support, they would also then be able to start their housing package process. So that's where in that safe, healthy, comforting environment, a person would be able to both heal from their medical concerns, but also get the social service help that they would need to be able to then exit from the medical respite care program, who would then follow them through the housing process and to become housed, but also make sure that their healthcare was still being taken care of. So it would be that strong care coordination that Angie was talking about. That's part of that GWIP services that the program that is run. And then finally, again, the ideal would be that they would then become housed, and therefore that they would be able to then have a much more healing life. Okay, so then from looking at what that ideal program is, we created what this proposed workflow is. And so this is really generalized. This is just big buckets, and it's kind of was just, okay, if we were able to then help help GWIP and all of the Medical Respite Collaborative operationalize this, what does that look like? Who's going to do what? And so we created what this, workflow really would be, where someone would come, they would be identified at the hospital as a perfect candidate for the medical respite program because they would have that eligibility gating criteria, and then they would get referred to a social worker from that hospital would contact the medical care respite program. Oh, and this is one piece that I should mention. One of the many conversations that we had in the collaborative program planning was who's going to own this in terms of where is this medical respite program going to sit? Is it going to be at a health center? Is it going to be in a shelter? Is it going to be, in a housing area? So one of the shelter providers, St. Vincent de Paul Mission of Waterbury, sort of stepped up and said, we will devote space, and we will start with so many beds, and we will put it in this part of our shelter, one of our shelter buildings, and we will be able to provide on-site primary care there. And then their long-term goal was that they would then develop a floor and eventually a building, which was kind of like their long-term goal to say this will be like a medical respite care building. So St. Vincent de Paul Mission is where the medical respite program would sit, and so then the client would be transported there. They would be admitted. They would be part of the medical respite care program. They would be sort of, they would be the patient there. So we used a lot of healthcare language about like admittance and discharge and things like that, because this was one of the foundations was that this would be a more primary care-based program. And then that's where the client would be able to receive their care, they'd be able to heal, and then of course over the process of 2 weeks, they would improve, and they would then be discharged from the medical care respite program into St. Vincent de Paul's general shelter bed system. And then from there, that's when they would work to get into housing. So all of that looks great on paper, and it was a beautiful workflow, and we talked a lot about who's going to do what and what the ideal plan is, but then what does that mean in terms of how you build the business case, and what kind of dollars are you looking at? Because you're like, this is great, but it's going to cost something, and so how do I do that? So I'm going to have my co-presenter here, Aparna, come up and talk to you about the business plan.
So that whole effort took a good couple of months, quite honestly, maybe even longer. There were several decision points, all informed by data, to really put those pegs in the sand, right? You can't do a business plan without having some concrete fundamental assumptions about the program. And so all of that work really informed what I would say the numbers behind the program, right? So what we ended up really wanting to do is a multi-step process of creating the business plan. Business plans, I'm sure at your organizations you have a process and you know what the inputs are required to create the right sort of, income statement, if you will, a pro forma, a budget for this project. So one of the things that we needed to do was, how do we cost this out? Now we know some of the who, the what, and the wheres. We need to also understand what the demand is, and we need to figure out what the funding streams are that will cover the costs of the program. So the first step is looking at capacity. So it was great that St. Vincent's was able to donate some space, but how much space? How does that align with the demand from the data that we were seeing from the hospitals and from the population? So you can always build a business plan top down or bottom up, right? So what we needed to do is look at some key specific elements: square footage, number of beds, hours of operation, length of stay. Length of stay, we don't have concrete information from this population based on all of their diagnosis, how long that they would need to recover and stabilize. In some instances, we had to look at secondary literature and also rely on some of those stakeholder interviews that Rebecca had mentioned. So the assumptions here was a good place to start in terms of typically 14 days for this population based on the criteria that was developed. We looked at also the we also wanted to look at scenarios. So that's something that I encourage folks to do is when you're looking at demand and capacity, think about building out your business plan under 2 scenarios, at 50% occupancy, 75% occupancy, or 100% occupancy. It was really important to understand scale and the resources and how you would scale up eventually when you get to full capacity of your facility. All of this information was really helpful, again, to start costing out the services and other activities for the business that would be communicated in the business plan. So in this next slide, what we really wanted to kind of go through and you heard Rebecca sort of talk about some of those specific assumptions, we need to really think about where the services were going to be provided. So the patients would be discharged to St. Vincent's. But who would be providing the services? It's one thing to have a location. You may be contracting or affiliating with other community-based groups to provide clinical services, or another community-based provider, like maybe Greater Waterbury Health Partnership, to provide care coordination. It's important to understand the who, what, where, and when, right? And so you can see each one of these by column title describes and displays the responsibilities that organization has in the medical respite program. So St. Vincent's was responsible for having the space. They were going to provide some eligibility assistance folks, some general supplies, facility maintenance. Security was a big part of this discussion. There were also discussions around who the clinical resource would be. So if there was going to be a nurse practitioner, how would that clinical provider contact someone at the hospital? What do daily rounds look like? Could that be with the hospital? Would that person or individual or resource be leased? Or could that be with the local FQHC, which is one of the stakeholders and partners in the Greater Waterbury area? And then you've got the community resource, which is the real backbone, I think, of the program, right? Sort of care coordinating, messaging, assembling, transportation, routing folks. And so we needed to kind of understand who the players are and what they're doing and how they're doing it. And so these, again, assumptions of where they're located, how the services are provided, and who's doing it was very helpful in developing the business plan. Once we got those who, what, where, how, and when's addressed, we then put costs together. And we used benchmarking data that was specific to St. Vincent's and some of the other FQHCs and hospital providers, looking at market rates for staff to calculate personnel expenses, and then other direct expenses just in the way the design of the medical respite was created for this initiative. At the end of the day, we came up with a daily rate of $350 per day. So remember, I told you we estimated about a 2-week length of stay. So it'd be $350 times those, 14 days that would yield you sort of, the potential revenue to cover those costs. In this instance, why are we looking at that daily cost rate, right? We want to try and understand and compare what the costs are to the system to treat the population. And so what we're looking at is really a cost avoidance. Many of the literature and many of the programs that exist today nationally are about creating savings in the system. And the cost avoidance, when you compare it to what hospitals may be incurring per day or per episode, is much lower than what the hospitals have to incur, right? And so this gets into, this is where I'm going to put my sort of financial hat and think about, how you get reimbursement, which I understand there's a whole session tomorrow on Medicaid reimbursement, so that's great. But when you start to negotiate for yourselves as program and community leaders and the ones that are bearing the risk of, ensuring the high quality of care and the success of the program, this ends up being an important piece of information for you to negotiate with those partners and with those payers, whether that's the state payer, the hospital provider, or whomever. You want to demonstrate that you're saving dollars in the system. And so that was a huge part of this exercise to really put together in a very conscientious, determined fashion of all of the cost outlays to deliver services to this population. We also went a step further and looked at one-time expenses. There's going to be data needs, communication needs, training needs. All of that had also come in so that we can identify what that amount is so that we can go potentially, I say we because I'm part of this program now, go to a funder and ask for seed money, right, to start this. All of this also informed the working capital that would be required, right, to start this initiative. Don't just think about day one and operating. You need a whole ramp-up period that you're going to have to fund, including these one-time expenses. So after you've got your costs figured out and you feel like these are the most reasonable cost outlays for the program, and you are looking at it as a per day rate, then you're going to start to think about, well, how do I cover my costs, right? There are multiple ways to think of funding strategies, and you've probably been hearing many over the years. When you are initially launching medical respite, as Greater Waterbury community was, you're going to look for funders and foundations to help launch this program. In this instant, we were the strategy was to get as many diverse funders as possible. So foundations, St. Vincent's was going to do a whole fundraising campaign and look for donors to help support. Angie and her team were, going to think about how to go to the community foundation in their area to look for, again, seed money to launch this. It has to be a diverse set of funding streams. Certainly hospitals are part of that discussion as well, if those are the patients that are going to be discharged to the medical respite program. As you start to get more evolved and you start to get more data and you start to demonstrate good quality and good outcomes, you can then also go to more expansive providers, not just the hospitals. But we tend to see some hospitals start to kind of pay those per diem rates, being the primary payer in the revenue sort of pie, if you will, for the medical respite program. But the trends that we're also seeing is that a lot of local foundations are now considering this medical respite program as part of a long-term strategy and initiative in changing the systems in their state. And so elements of the program, like the community care coordination piece or the community health worker piece, can be funded for the specific focus around medical respite. The future of funding really is predicated on what Medicaid's going to do. If we can get more states to start including that as part of their reimbursement and eligibility of benefits, then that will go a long way for making medical respite a more formalized, expected program nationally. And we're starting to see it, and I'm sure you'll get more information in tomorrow's session. But the point of this slide is, again, to show that there needs to be, and there is, as it exists, a diverse set of funding streams that are holding up medical respite, which is challenging, but also an opportunity to start, pushing the program's benefits forward so that we can formalize and make this into a payer benefit at the Medicaid, in terms of public insurance and Medicaid. So I'm going to close this out, and hopefully there are some questions that you all might have for us. What I wanted to share are just some basic, recommendations through this process. You heard sort of the story of Greater Waterbury and some of the challenges and the data that proved out the need for medical respite. The process was arduous. We were really lucky to, again, have those stakeholder interviews. There's a tremendous wealth of information that the association has put forward that were guiding parameters in developing and designing this program for Waterbury. But we kind of wanted to break this out into 4 buckets. One, understand and identify the partners that are going to be sticking with you through this process. Partnerships, as you've heard, I think in the previous session and maybe throughout this conference you'll hear, is and to put it bluntly, who you're going to be in bed with, right? And who are you going to kind of work together and in this committed relationship to serve these shared populations. And it's really important to understand who those folks are and will be by your side. And you saw the tremendous amount of diverse, different types of stakeholders at the table during this process, which at sometimes became a little unwieldy, but you know, we needed everyone's voices to be heard, quite honestly. And then you've got to sort of develop those operating procedures. So there's a lot of due diligence. Give yourself the time to go through each operating step that Rebecca had shared in that workflow. There are, I can't tell you how many questions come up and you're brainstorming in that instance a solution that required 4 or 5 different perspectives at the table. The other recommendation just is to make sure your data is clean and good. You heard Becky talk about the lack of data. We had to rely on some secondary literature. We had to make some inferences, as Becky had shared, on the information that we could sort of get in our hands before those data management agreements were released. But the quality of the data is really important to help, again, inform that design of your medical respite program. You need to understand the who, right, and the what kind of needs that population requires to inform the type of services that'll hold up the respite program. And then from a funder's perspective, start to build that consensus. Start to do some talking, priming, headlining of the medical respite program in advance. I would say this discussion started about a year or 2 before we actually did the work. And so it takes a little time to build that, that awareness, right, and get folks to the table. And we had, again, those representatives from public, state, community-based organizations and the providers. So it did take some time for folks to realize, like, this is happening, and we're finally doing the work. All right. I think that's all I have. Any questions? Oh, there's some questions. Oh, great.
Hi, thank you so much. I have a question related to the data you just mentioned. You said you used the 2 key terms, clean and good. I'm wondering if you can just expound a little bit about what makes it clean data and what makes it good data for the context of which you're presenting on.
I'm going to let our data person answer that question.
So in terms of clean data is we needed to have a methodology that was clear and outlined so that I can speak to any of the questions that the stakeholders were coming forth with, like, well, what does this represent? And how did you get this? And how did this? So I had to have a clear methodology of where I came up with these numbers. And so I think that is really, and I had to take out outliers, different things that I think I heard in the last session, looking at diagnoses and understanding what diagnoses would require the medical respite services that we would provide. And good data is really, I wish there was like this miracle that everyone would get on the same page, because it's really hard, but we just try to do our best to come up with, like I said, a clear methodology.
I can also just kind of follow up on the good data thing, right? And and speak to some of the challenges. And so if you're working in I want to advance to the context slide so you all have that. But in terms of working in a system that, in our health system, we have multiple electronic medical record systems, okay? And so that's where I think a lot of discrepancies in data are happening, because our two hospitals are both using different EMRs. One is Cerner, one is on Epic. FQHCs are using something else, and so obviously field matching becomes an issue because they're not all collecting things the same way. Good data is also being clear, like Becky said, about methodology, but what you're looking for. And so when you are requesting data from the hospitals, to make sure that you're giving them the right breadcrumbs, right? So that you're getting the consistent answers and back from each of those entities to sort of measure the type of information you're looking for. And in our case, like Becky said, there was no, the hospitals weren't collecting the housing status indicator. And so inferences that had to be made, we had to get creative with like, well, if somebody is not listing an address, does that mean they're homeless? Or if somebody's listing the shelter address, we can infer that that means they're homeless, right? And so, there was a great deal of probably a lot of pivot tables. That goes beyond my expertise. That's what I lean on her for. And a lot of cross-referencing to try to get a data set that made some sense. And I would like to say also that, we got a data set from Waterbury Hospital, but because of barriers with our data sharing agreement with St. Mary's Hospital, we were unable to get a data set from there. So you could infer that there's duplication amongst those two hospitals, which are about 5 miles apart, not even, right? And so we're already sharing a lot of patients. That number is probably 30% higher, but that there is duplication in those patients. So data is a huge, whole other subject. Yeah, we don't have enough time for that.
I did want to say one of the most important things that I've learned in all of this is to really be equitable in your data as well, and making sure that you have all the data points you need to come up with whatever information you're being requested. So if somebody is asking us, like what is the homeless population in Waterbury and what does that look like? You have to take into account more than just their age and date, like the demographics. You take in everything, and then when you make your statement about that need, to make sure you list out all the information. Like, you have to be very clear so that everyone can know what this actually means and not make their own interpretation of the data. That's something like so clear as what does the homeless population look like would be something that you want to make sure you're very clear in.
Hi, my name's Eddie Estrada. So my question is more towards the sustainability of the program. So once, you have the funders, they give you that one-time cost, they're not going to want to continue funding something. They want to fund something different. Did you find that the project was sustainable with in partnership with the revenue stream that came in with the hospitals and the managed care reimbursements?
Well, this is probably a good time to say that they're still in process of implementing the medical respite program. I think in sort of my national observation, and I welcome other folks to kind of chime in here, is that the pathway to getting that sustainability reimbursement from the providers is a little bit more clear than getting the reimbursement from the state local resources. So you're absolutely correct, right? When you secure funds for launching a program, these are one-year demonstrations. You may be able to negotiate a multi-phase approach with the funder, saying year one, we want $100,000 to do this. If we hit all our performance metrics, then year two, we're gonna ask you to invest. And most foundations will do that because they don't wanna just leave at one point. They wanna be able to tell the state, the world, that they were able to launch something successful, and here are the outcomes and performance indicators that prove that out. So, when you are negotiating and securing those funds, think about the phasing and how you can get continuous phasing, I would say from a 3 to 5 year mark, if possible, which is hard, I get it, but be very specific in what your asks are, if that's helpful.
Yeah, thank you. The other.
Yeah, I mean, if you could get payment from the hospital, that, again, that's a better sort of outcome from this. It's just when the hospitals start to see payers' plans start to, want to pay for this. Like, I'm going to say VBP, value-based payment, right? So that is starting to, medical respite and the idea of patients accessing those services are now being woven into contracts with health plans. So sustainability there are different milestones to sustainability.
Great, thank you. One more. So you mentioned that in this model that you have in your area, it was 14 days, the average stay. One of the things I'm hearing for this model is housing first, right? The ultimate goal is to get the individual experiencing homelessness get them housed. In our neck of the woods, because of the lack of affordable housing inventory, it takes anywhere from 45 to 60 days. And so what would you recommend the messaging to someone like us who's looking at starting this, working with the hospitals, but probably determining that it's going to take longer than 14 days?
Good question. I'm going to have Angie answer that one.
Yeah, that's a big question. And I think the important thing that you are highlighting is that, every community is going to look different in terms of the need, right? And so, if your average stay is predicted to be much longer, obviously there could be, more costs associated with that. So I think you just have to look at the whole picture of what in your community is causing those longer stays, right? And you have to really make that whole case. I mean, I heard Aparna talking about sustainable payment systems and reimbursement, and some of the struggles that we are going through on our end is, our health system looks different than many other health systems, right? So there's a lot of budgetary concerns now. Yes, everybody wants to be written into the operating budget and have a line item. That's our dream, but the reality is that, the hospitals are still rebounding from a pandemic where they could have suffered substantial financial losses. They're still dealing with staffing shortages, all kinds of stuff, and everything's on fire, right? They know that this is a priority, but so is everything else, including keeping their own staff. And so I really, I think the long game for this is some type of reimbursement, but on the front end, it's probably you have to do some thinking about multi-year grants with private foundations, where you could, like Aparna said, you could get 3 years, and you could take a whole year to implement, and then 2 years to scale a pilot program up so you can get some outcomes, and then take those back to your providers, your hospitals, and say, like, listen, this is like we're making the case, this is, the true cost analysis of this actual pilot program that's happening. And I know, I think I heard you, Brooks, say something earlier this morning about being careful about that language that you're using with your providers around cost avoidance or cost savings. Something that we hear a lot is, well, you're not saving us money, you're taking away our visits, right? And so how are you going to quantify the community benefit part of what you're doing in homeless respite care against the argument that you're always going to get from the provider end, which is, well, now we can't submit a claim on this person anymore. And so your health system is going to look different than ours. In our health system, 75% of our patients are on Medicaid. And so those hospitals are looking to that 25% of patients who are commercially insured to pick up the slack. And so that threshold, that tipping point looks different from where you are. So you've got to do your homework and figure out what is the tipping point in your health system before you can have a conversation with hospitals around how they might sustain this. Now, should they be sustaining it? Absolutely, right? There are things in homeless respite care that are not necessarily quantifiable, right? There's a lot of redistribution of energy and staff attrition and strain on the health system that comes from needing to work with the homeless population in emergency rooms and not having the resources and knowing how to do that, right? And a heck of a lot of time wasted when they don't understand how to collaborate with community providers that can do it better. So it's a very long answer to a pretty direct question, but I think like the short end of it is you got to look at your own community's scenario first, and then do some research about the way reimbursement works and the financials in your hospital systems to understand how they might perceive the benefit and the cost kind of on both sides, if that helps.
We're going to take one more really quick question and then get. Okay. Sorry. Thank you so much, you all, for that presentation.
We'll be around for questions out there in case anyone, has dying questions, and our contact information is here. So please reach out if we didn't get to you.
Just to answer a quick question as I'm pulling up my slides, we are going to share the slides from everyone's presentations after today. So all of this good information, contact information will be available to you after probably next week when we're all back in office, I'll be honest. And we have small group discussions later this afternoon, so lots of time for continued conversation. So I am setting a timer because I'm the person standing between you and lunch. I'm going to acknowledge that. But I'm super excited about the brief presentation today about talking about a trauma-informed environment in the facility. So this is a great primer talking about putting together a program and design, and we're going to talk about those different pieces of it the rest of this afternoon. So I'm Caitlin, for those of you who I haven't been on a Zoom call with, but I've probably emailed you. So great to be here with all of you today. I'm part of the team with the Medical Respite at the Council and NIMARC. I'm also an occupational therapist, which I could talk about for hours, but I'm not going to. But if you're interested in thinking about OT in your respite setting, that's me, I'm your girl. And I really just am an advocate for healthy spaces as we go across and thinking about working with medical respite and people experiencing homelessness. So my other disclaimer is that this is going to be really brief. If you want to dive deeply into this, we actually have an hour-long webinar that we did last summer available on our website. So I'm going to give the primer and then just know there's more opportunity for learning. So probably not a surprise to anybody here in this room, but trauma is a significant issue when we're talking about people experiencing homelessness. It's something we need to be thinking about in every piece of the work that we're doing and the services we provide and the programs that we design. Especially because even if trauma is not immediately present, it has long-lasting adverse effects on the person that can pop up in a number of ways through our emotions, our behaviors, even our physical response, and there's data to show that. So when we are trauma-informed, right, we are recognizing that trauma exists, even if we don't know for sure with the person. We should make the assumption that it's there. We're responding to it when it is present, and we are avoiding and resisting re-traumatization. And that's really where the environment piece comes in. How can we set up our structures and spaces to not perpetuate traumas that are experienced, especially that often occur within our healthcare systems? This is really important for the people that we're working with because we know that trauma is a contributor to people becoming homeless, right? That is something that causes that. We also know that trauma is a result of homelessness. And I also want to bring into light, especially in the medical respite space, there might be really recent trauma as a result of the medical issue that brought the person into the hospital, right? And that transition from hospital back into the community can also be very traumatic. So there may be people who have these personal histories, but coming into the respite program may be very fresh with a new diagnosis, a new change in physical function, a new concern about safety, self-care, whatever that might be. So that's really, really why it's important that we're thinking about this when we do our care. And when I say environment, I mean all pieces of our environment, right? It can be natural elements, material resources, politics, and policies, and that's why trauma-informed structures, systems, policies, and procedures are so important, because that kind of dictates how spaces are used. And why does it matter, right? Why are we thinking about this beyond? Because you can have really great direct person care, clinical care, but the environment still matters quite a bit, right? Especially because for our community members experiencing homelessness, you're not welcome is a sign that the environment gives them all the time, right? Barbara spoke about encampment disruption earlier today. The environment can be very hostile, right? And there's actually a term for hostile architecture, which is displayed here, and people are feeling very unsafe. And we want to do the opposite of that when we're in medical respite. We want to create dignity, opportunity for dignity. We want to create opportunity for healing, and it to be a place that someone wants to spend their time, and really just welcoming for everybody that walks through the door, whatever that might be. From a more technical standpoint, a trauma-informed environment is supported by our standards for medical respite care. Throughout the standards there, it speaks to the importance of having trauma-informed spaces for people to go. So, brief overview of the why. So, what is it? What do I mean when I say trauma-informed care? And I'm gonna talk through just sort of some key ideas here. And what I'm gonna say is there's not one perfect way to do it. There's not one facility or checklist that I would say, here, if you do this, you're going to be trauma-informed, right? It's sort of some clinical reasoning, some iteration of ideas, some concepts that you can figure out what that looks like in your space. The other caveat I'm gonna say is that I know the kinds of spaces that you all are working in. Not everybody has the opportunity to build their space from the ground up. Not all of these are going to be available options, but doing what you can in the space you have can make such a significant difference. But it's important to remember too, trauma-informed, there's not one global, well, if I'm trauma-informed for this person, I'm trauma-informed for everybody, right? Experiences and iterations of trauma are individual. So what is trauma-informed for one person may not be trauma-informed for someone else, right? There are some folks who do not want to share congregate sleeping spaces, right? That is triggering and traumatic. And there are people who do not feel safe in dark rooms by themselves, right? And so how do we sort of balance that? And one of the things to do with that is offer choice as much as you can throughout your program. Be flexible about what you're offering, having different options, having different things that people can do and choose for themselves, because there's a lot of power in choice. And thinking about the rules that you have in place. Are there things that are rigid, and why are they rigid? Sometimes we create rules because we think that that's the best thing to do, but maybe can we be flexible? How do we work around this? How do we say this is our guideline versus this is a no-negotiable, right? And just recognize that, unfortunately, in medical respite, especially because of the shorter duration of time that people are there, even if you have the most trauma-informed environment possible, you're not going to be able to prevent and eliminate all triggers. And that's why training your staff around trauma-informed care, de-escalation, is really, really important, because people are going to encounter triggers. They're going to leave your program to go to medical appointments, interact with people, whatever that might be. You're never going to be able to prevent all of it, but you can respond, right, back to that original R. Be ready to manage and support the person, and think about how can we respond to this, provide the person what they need to be able to take care of themselves. So choice can look like a lot of different things. Choice can be giving people options. Don't make everybody do their showering in the morning at 6 to 7 a.m. Can people get to the bathroom all day so that they can shower when they need to, right? Do we offer opportunity for private space? Even if you're in a congregate setting, is there a room people can use to do their own health care, right? Making sure that you can block off spaces so that they're not around everybody all the time. Allowing and acknowledging we all have different routines and preferences for when we do things throughout the day, offering that as much as possible. Giving choice to participation. We all have our own preferences around how much we're around other people and how much we want our alone time. Giving people that choice and ability to make that choice for themselves. Similarly, very functionally, different choices in lighting to allow people to be able to rest in the way that they prefer to rest, and even simple things like bedding, right? Some people don't want any pillow, and some people want 4 pillows. And that's one of those rigid rules of like, everybody gets 1 pillow and 1 blanket. Why, right? Like thinking about like, if you want another pillow, take another pillow, like get comfortable, right? That's the goal, we want you to rest. And even just different seating options, things that will make people feel comfortable in spaces, these can all contribute in really small ways. Safety is a really big one, both in terms of physical safety, but also our emotional safety, right? Can the person do what they need to do in a way that makes them feel safe? Accessibility, as I said, I'm an OT, so like, this is where my heart lives. I love talking about bathrooms, but thinking about how do we make our spaces accessible, both mobility and physically, but also for folks who are dealing with cognitive needs. Again, that's really prevalent and common amongst the population, but also when you're dealing with acute medical issues, your brain is not at its best. And then also emotional support. So this is just a demonstration I like to give around accessible versus inclusive, right? So we have our first picture up here. This is not accessible, right? Only people who are able to use 2 legs to ambulate upstairs can really get into this building. Picture 2 is accessible. There's stairs at the front, and there's an accessible entry that the person who maybe can't take the stairs can go around the back of the building and enter, right? This is often what we see. It is accessible, but But inclusive is this third picture where everybody enters the building in the same space, has access to the same resources at the same time with an equal amount of effort. So that's the goal, right? And there's a difference between meeting ADA requirements, which ensures accessibility, versus being inclusive. So there's a lot of nuance to that. I'm always happy to talk more about it, but just to get thinking about it. And the best people to tell you this are the folks who are living in your programs, right? What is accessible, what is inclusive, and what is not? There are some small things that you can do to make your spaces more accessible, even if you can't do a full bathroom redesign, right? Making sure that your tub floors are non-slip, putting in grab bars for people to use. There's a lot of options around bench seating, chair seatings, and not everybody has the same preferences, so having a couple of different ones so people can use what makes them feel most comfortable. And then again, if you have the opportunity, redoing your bathrooms to be fully ADA accessible is incredible. I know that's not easy for everybody, but there's definitely a spectrum of things that you can do to make these spaces safe. Similarly, for folks who have cognitive needs, right, making sure that your signage is clear, that the key information is central and organized. Can people easily find who they need to talk to? Who is their case manager? Who do I talk to in an emergency? You know, if there's a maintenance issue, what do I do, right? Especially if you don't have 24/7 on-site staff, making sure that people can find that information. We don't want the bulletin board that I just put an X through there, right? Where we've put up every poster ever and nobody ever takes anything down, because you look at it and you're like, I don't know what I'm doing, right? And we kind of walk away. And I think we can all relate to that experience as we're navigating a novel conference space this week, looking at the map going, I don't even know where I am, so how would I, right? Thinking about how that supports people in navigating these different spaces, and really ideally having somebody available to answer questions and having that be part of their job, right? If you are like, oh, just talk to your nurse when you have a question about where to find the bath towels. I'm sorry, nurses in any program I've ever worked in are incredibly busy people. Do you have somebody kind of in your milieu who can help find the bath towel, who can help find the phone number, who can answer those questions? That relieves a lot of stress for everybody, but helps people feel supported in a way that they can find and get what they need. Also, really making sure people can store their personal belongings, ideally in a way that they can access them whenever they desire to, and don't have to engage with staff to be able to get them. I think that's really, really important for people who've experienced a lot of loss of personal belongings. And it can be really simple: lock boxes under a bed, storage lockers, having external units for people who have additional stuff, right? I know space is a huge challenge, so can we provide a space for people to keep some of their extra items that they don't need day to day on the unit while they're in respite, to kind of balance that challenge, because I know there's other safety concerns, right, about bringing everything in, and in some cases just not the space for it. And then again, if you're in a more congregate space, like creating privacy spaces as much as possible, so that people, you know, if you're injecting insulin, you don't want to do that in front of everybody else on the floor, right? If you're taking care of a wound, you don't want to do that. How do we do that? Creating those spaces for people to meet in, meeting with their providers, avoiding having personal conversations in central areas where other people can hear. And just a note that even having some harm reductive spaces can exist with privacy. Choice, flexibility, right, is kind of boiling down to that. So a lot of different options, again, on how that can happen depending on the space that you're in. I do like talking about bathrooms, and that's my favorite picture on here, is thinking about what a difference it makes in feeling secure when you're showering, when there's a door versus a curtain to everybody else, right? I think we've all probably had those experiences, but thinking about your everyday, even that sort of simple addition, you didn't even have to redo all the bathrooms, but maybe just making some of those changes help people feel more safe and comfortable. And then finally, promoting health and well-being. Thinking about the emotional health and piece of things for creating opportunity for community, having formal groups, but also having opportunity for people just to hang and have a good space. We talked about how much Krista likes to talk about having things like recreation, right? Do we have games? Do we have activities? Do we have things for people to engage in throughout their time, so that, you know, we're building out that emotional piece of things too? Opportunity for calm. Programs, spaces can get really chaotic. There's a lot happening during the day, right? But do we have spaces where people can just go and sit, be quiet, take a deep breath, right? It changes so much when that sort of decreases, and can do a lot of prevention of things, and just allowing people a space to be able to calm. And then opportunity for other activities that are important. Do we have adequate space for people to fold their laundry, to do exercise if they want to do tons of paperwork that is required to engage with healthcare systems and SSI and all of those other things, right? Is there a desk where someone can sit at and comfortably work on that so they're not like trying to write with a pencil on paper on their bed? That doesn't work, right? Thinking about those other spaces, how do we create that so people can work on their personal goals? And again, don't necessarily, staff is not a gatekeeper of that. We have a space where people can do that when it's right for them at their choice and time. And then ideally, all of the above, my Baltimore friends might recognize this space. Thinking about how do we do this, and I love this picture, the two gentlemen pictured here they were landscapers in a former life, and so this project was to green a space that was not very green in a congregate setting, really meaningful for them. And then we were also working on some pain management and movement strategies. You can do a lot with one thing, and you can do a lot in spaces that are not always the prettiest to look at to start with, or maybe not the most trauma-informed initially. All of that being said, there's some challenges, and talk through that. Sometimes it can be hard to be flexible, probably impossible to accommodate everybody's needs, right? But thinking about communication, right? One of the things is just giving people knowing what to expect, knowing what can happen, what can't happen, and being really clear about that. And sometimes you can say sorry, right? It's like, I'm sorry that this is not something that we can do. I see that it's important to you. You can still hold those boundaries, but it's so much easier if you're communicating that to people and not just saying no and walking away from the conversation, and validating, perhaps, when people feel frustrated by that. And then thinking about, again, what is reality? Of course, it'd be really nice for everyone to have like plush recliners in their space, but upkeep of that is probably not very realistic, right? So making choices around what can we maintain, what minimizes other risks that we might be concerned about. And certainly cost can be a huge issue. Some of these adaptations and things can be lower cost, but some of them are expensive. Furniture is really expensive right now. Other challenges is that you are not in control of your environment, right? If you're sharing a space with someone else, you might not even be able to paint the walls or put things up on the walls, right? That would create that. There might be procedural barriers. Maybe the values of the building owner don't align with what you want to do. Thinking again, being creative about what you can do in the space and what you can't do. Again, those small changes can go a long way. It's not an all or nothing kind of situation. I heard this, we don't want people to get too comfortable here. I'm going to challenge that notion that we do want people to be comfortable there, right? And that's where the communication piece really can solve some of that, of being very clear. This is transitional, this is short term, right? We're going to talk about like in 30 days, right? Being really clear about that time frame. I know it doesn't solve all of it, right? There's always going to be some folks who have trouble transitioning out, because transition is hard. But because of that, we don't want to avoid creating comfortable spaces for people. And sometimes it requires a paradigm shift, right? If you're working in a space that's new to trauma-informed care in general, there's going to need to be some training and some culture change, and that takes time, right? It takes as much time as it does to get funding. So being patient with that is fine, but I think once you start doing little bits of it and seeing small pieces of success, that's when things start to snowball in a positive way. So where do we start? My timer is like running down here. There's some suggestions here for you to think about. What do we need to look at within your program? We have a resource that's a checklist for creating a trauma-informed environment, which aligns with this presentation, so you can kind of go through, and it helps you think about these different things. Again, there's not like if we check 100% of these things, we're perfect, but it's to help generate ideas and think about what you could do or what you could modify or change. The other piece that I'm really going to highlight is talk to the people in your program. Talk to the people who are using the space. What do they not love? What do they love? What would they suggest? People are incredibly creative, and they're the ones living there. They're the ones there all of the time, that those suggestions are going to be the most important ones to think about. And then finally, think about immediate versus long-term, right? Hanging some pictures up that create a more welcoming space is a small short-term thing versus maybe planning out a budget and a funding effort to create more accessible spaces. And just note, you don't have to do it alone. Again, the slides are going to come out, but there's a whole bunch of different places and spaces where you can get some support. You don't have to come up with this by yourself. There are people who've done it. There are people who will be happy to do it with you in your communities. So I'm going to stop there. It's lunchtime, so if you have questions, please come talk to me. I'll be hanging out here. Otherwise, enjoy your lunch. We will be coming back here at 12:45. Starting there, lunch is downstairs where you had breakfast.